Welcome to The Explainer. Today, we're diving into a condition that can be super confusing because it often hides in plain sight: primary hyperparathyroidism.
You know those days when you're just feeling tired, kind of achy, and just not yourself? A lot of us just chalk it up to stress or, just getting older. But what if all those feelings were connected to one single, totally treatable problem?
Well, in the medical world, they've got this great little rhyme for a classic set of symptoms: bones, stones, moans, and groans. And yeah, they seem all over the place, but they can actually all point back to one specific underlying condition. So what's connecting all these dots? It's a condition called primary hyperparathyroidism, or you'll hear it called HPT. And as you're about to see, it's a perfect case of how one of the teeniest glands in your body can cause some surprisingly big problems. Okay, so what's really going on here? Tucked away in your neck are four tiny parathyroid glands. Their whole job is to make something called parathyroid hormone, or PTH, which is basically your body's calcium manager. With HPT, one of these little glands just goes rogue. It starts pumping out way too much hormone, which then causes the calcium levels in your blood to just skyrocket. I think this is the best way to picture it. Think of it like a thermostat for calcium. Normally, that thermostat keeps your calcium in a really tight, healthy range. But with HPT, that thermostat is busted. It's just stuck on high, yelling at your body to release more and more and more calcium into your blood 24/7. And you might be thinking, well, what breaks the thermostat? For the vast majority of people, we're talking 85 to 90% of the time, the culprit is a little non-cancerous growth called an adenoma on just one of the four glands. So it's not cancer, but it's just working overtime when it shouldn't be. So with all these vague symptoms, you'd think figuring this out would be some huge medical mystery, right? Actually, it's pretty much the opposite. Diagnosing HPT is remarkably straightforward. The whole case gets cracked with one simple blood test. That's it. A doctor sees these two things together, a high calcium level and a high parathyroid hormone level, and boom, that's the smoking gun. Diagnosis confirmed. Okay, so the blood work confirms the diagnosis. Now the next phase begins, the detective work. The surgeon knows there's a problem, but now they have to figure out exactly which one of those four tiny glands is the one causing all the trouble. And this is where all the cool modern imaging tech comes into play. Now, this is a really important point. These scans are not used to diagnose the problem. The blood test already took care of that. What these do is create a super precise roadmap for the surgeon, literally showing them, okay, this is exactly where you need to go. And that roadmap leads to one place. Because for primary HPT, you can't fix it with pills or medication. There's only one way to fix it: surgery. To remove that faulty gland is the only cure. Now, the surgery itself has had a major glow-up over the years. The old school way involved a bigger incision so the surgeon could poke around and look at all four glands. But now, thanks to that imaging roadmap, most people can get what's called a minimally invasive parathyroidectomy, or MIP. It's a much more focused operation with a tiny incision and a way faster recovery. All right, so picture this. The surgeon has followed the map, they've removed the gland they think is the problem, but how can they be 100% sure they got the right one? How do they know the patient is cured before they even wake up from anesthesia? It's all thanks to this brilliant process they can do right there in the OR. They measure the hormone level right before taking the gland out. Then they take it out and check again 5 minutes later, and then 10 minutes later. See, that hormone has a really short lifespan, so if they got the right gland, the level should just crash. And here's the magic number they're looking for: a drop of more than 50% from where it started. If they see that PTH level plummet, it's confirmation. Mission accomplished. They know, right then and there, that they've cured the patient. It's amazing.
So, we've walked through the problem, the diagnosis, and the cure. What about after? What's life actually like for patients on the other side of this procedure?
Well, first off, the success rate is, frankly, it's incredible. When an experienced surgeon performs this operation, the cure rate is somewhere between 95 and 99%. That makes it one of the most successful surgeries in all of medicine. And the benefits are just profound. We're talking about real life-changing stuff. Bone density gets better, stopping osteoporosis in its tracks. If you were getting kidney stones, there's a 90% chance that just stops happening. But beyond all the clinical stuff, patients just feel better. They report having more energy, a sharper memory, just a massive improvement in their quality of life. So I think the big takeaway is this.
If you or someone you know is suffering from all those vague bones, stones, moans, and roans, the answer might not be a bunch of different treatments for a bunch of different problems. It might just be one tiny gland and one highly effective surgery that fixes the root cause and gives you your life back. It's pretty amazing to think about.
Welcome back to The Explainer. Today, we are diving into something truly fascinating. A surgical procedure that went from this big, major operation to a super precise, targeted mission. And believe it or not, it's all thanks to a secret alphabet.
All right, so here's our game plan. First, we're going to look at how this surgery completely changed, the old way versus the new way. Then, we'll get into how surgeons create their roadmap before they even make an incision. After that, we'll crack the code, this secret alphabet they use. We'll see how that alphabet tells them whether to use the front door or the back door approach. And finally, the coolest part, how they know they've succeeded, literally in minutes. To really get how big of a leap this is, we got to take a step back and look at the problem they were trying to solve. For a long, long time, parathyroid surgery, well, it was a much bigger deal.
Yeah, this really paints a picture, doesn't it? On one hand, you have the old way, a pretty big incision, a longer recovery time, and basically an exploratory search inside the neck. And on the other hand, the new way, what they call a minimally invasive parathyroidectomy, or MIP. We're talking a tiny incision, way faster recovery, because it's a completely focused mission.
So what is MIP, really? Well, it's a super smart approach. See, it's all built on this one key fact. Something like 85% of hyperparathyroidism cases are caused by just one single rogue gland. So instead of going on a wide search for all 4 glands, the whole goal is just to find and take out that one troublemaker.
And for the patient, the benefits are huge. You're talking less time under anesthesia, way less pain afterward, a much smaller scar, you get to go home sooner, there are fewer complications, and it even costs less. It's really a win-win-win all around.
Okay, so how do they actually pull off this targeted mission? Well, it all starts with one absolutely crucial thing. You have to have a perfect map before you even think about starting the journey. And this is the bottom line, right here. No map, no mission. That preoperative imaging isn't just a nice to have, it's a must. If the scans can't pinpoint the exact location of that problem gland, they can't do the minimally invasive procedure. It's as simple as that. They'd have to go back to the old exploratory way.
So what are they using to make this map? It's like a whole high-tech toolkit. Surgeons will often use a combo of these advanced imaging techniques, things like ultrasound, these really sophisticated 4D CT scans, and sestamibi scans, to build this incredibly clear 3D picture of exactly where that target is hiding.
All right, now here's where it gets really cool. So they found the gland on the scan, but how do you describe its precise, sometimes really tricky location to the whole surgical team? Well, you use a secret alphabet.
And this isn't just a bunch of random letters or some complicated medical jargon. No, it's a brilliant system, a standardized language that gets everyone from the person reading the scan to the surgeon holding the scalpel on the exact same page. It's a universal code for X marks the spot. So let's break it down. First up, A is for adherent. Think of this as the A+ student. It's the most straightforward location. The gland is right where it's supposed to be, almost stuck to the back of the thyroid. This makes for a super predictable surgery.
Next, we have B for behind. This little guy has kind of slipped backward from where it should be, and it's hiding out in the groove between your windpipe and your esophagus. So you can imagine it's a little bit trickier to get to.
Then there's C for caudal. Caudal is just a fancy way of saying downward. This gland has started to migrate down, closer to the collarbone. And this one is important because it's a spot that was often missed back in the day with the older, less targeted surgeries.
All right, D stands for dangerous or difficult, and there's a very good reason for that. This is when the gland is sitting right on top of or dangerously close to the recurrent laryngeal nerve. That's the super delicate nerve that controls your voice. So you can see why any work here has to be done with extreme precision.
Okay, now for a sigh of relief. E is for easy, and it's exactly what it sounds like. This is the best case scenario. The gland is located in a really superficial spot, not buried deep in the neck, which makes it the easiest one to get out. The surgeon sees this on the map and they know it's going to be a good day.
F is for fallen. Now, this gland has taken an even bigger trip downward than the C-type. It's actually dropped into the area of the thymus gland, which is an organ that sits right in the upper part of your chest.
And last but not least, we have G for gosh. And you can totally think of gosh as in awkward. This is a super rare situation where the parathyroid gland actually got stuck inside the thyroid tissue itself, which, yeah, is pretty awkward. It means the surgeon might have to take out a piece of the thyroid just to get to it.
Okay, so let's recap. The team has the map, they've used the secret alphabet to label the target, and now that single letter dictates the entire game plan. It basically tells the surgeon which door to use, the front door or the back door.
It's really pretty logical. The front door is just a small incision right in the middle of your neck. It's perfect for grabbing those glands that are out in front, like an easy type E or a fallen type F. But for one of those glands hiding deep in the back, like a type B or C, the surgeon needs to use the back door. That's an incision on the side of the neck that gives them a much more direct shot at that tricky spot.
Okay, but this next part, this is what I think is the most mind-blowing piece of the whole puzzle. It's how they confirm that the mission was a success, while the patient is literally still on the operating table. I mean, really think about that. How can a surgeon know for sure that they got the right gland and that the patient is actually cured before they even wake up?
Well, the answer is an incredibly fast blood test. They check the level of something called parathyroid hormone, or PTH. Now, the cool thing about this hormone is that it disappears from your blood really fast. Its half-life is just a couple of minutes. So they take out the gland, they wait about 10 or 15 minutes, and they draw some blood. If that PTH level has crashed by more than 50%, boom, they know they got the bad guy, mission accomplished.
So when you put it all together, every single part of this process, from the fancy imaging to the secret alphabet to that real-time blood test, it's all designed to do exactly this: limit the surgery, shrink the incision, and make the patient's recovery so much better. It's all about maximum precision for minimum impact.
You know, this whole evolution from a wide-open exploration to a laser-focused surgical strike, it's just a total game changer. And it really makes you wonder, doesn't it? What's next? What other complex surgeries are going to become these kinds of targeted, minimally invasive missions in the future?